Hello. In this video, we'll be talking about the rest of the chapter on death and dying. So we'll be picking up talking about palliative care, hospice, family caregivers, advanced directives. We'll also talk about the cultural differences in end-of-life decisions, the different types of euthanasia and the controversy surrounding them, some of the funeral rituals of a few different religions, what green burials are. We'll also differentiate between grief, bereavement, and mourning. We'll talk about Kubler-Ross's model of grieving and some of the criticisms of it, as well as the dual process model of grief. We'll also talk about the impact of losing a child and parent, prolonged grief disorder, the 4 tasks of mourning, and finally, the importance of support groups for helping those in grief. We're gonna have to skip ahead. So different types of care. Curative care is designed to overcome and cure disease and illness with the goal of complete recovery. And it has been criticized, though, for ignoring the goals regarding improving quality of life for people who cannot be cured, because you can't cure everything. So palliative care, this is where palliative care comes in. It focuses on providing comfort and relief from physical and emotional pain to patients throughout their illness, even while they're being treated. So even if they are receiving curative care as well. Previously, palliative care was only used for terminally ill patients, but now it's also used for patients with chronic illnesses like cancer or heart disease, and it is a core part of hospice care. So hospice programs were developed in the United Kingdom due to Cicely Saunders' work, and then were popularized in the United States by Elizabeth Kubler-Ross. So hospice care, whether it's provided at home, in a hospital, a nursing home, or hospice facility, involves a whole team of professionals and volunteers who provide terminally ill patients with medical, psychological, and spiritual support, along with support for their families. To qualify for hospice, patients must have 6 months or less to live and agree to forego invasive procedures. The main goal of hospice care is quality of life rather than quantity of life. So helping both the terminally ill person as well as their family prepare for death in ways that are satisfying to them. There are cultural differences in regards to hospice care. Many African American families think medical treatment should be pursued until the person dies, and that God will decide that time. Chinese American families may feel uncomfortable discussing issues of death, especially in front of the ill person, and we'll dive into some of those cultural differences a bit more in a few slides. So family caregivers, 29% of American adults are caregivers for someone who is dying or chronically ill. 2/3 of caregivers are female. Most caregivers are not getting home visits by healthcare professionals, and they typically have little training or guidance. Caregiving is physically, emotionally, and financially challenging, and many caregivers are also employed and are trying to balance caregiving with other family and workplace responsibilities, in addition to trying to find time to take care of their self as well. The prevalence of chronic disease is rising, as is the need for caregivers. With the baby boomer population entering late adulthood, fewer family caregivers are available. Let's talk about advanced care planning. So advanced care planning refers to all documents that pertain to end-of-life care, including advanced directives and medical orders. That really the best way to have your wishes followed is to do some advanced care planning. So advanced directives include documents that mention a healthcare agent and living wills, And living wills are different than estate wills, which basically note who receives what from you, like divides up your assets how you want it. Living wills, on the other hand, are written or video statements that outline the healthcare procedures that a person wishes under certain circumstances. So what treatments you do or don't want in case of terminal illness, coma, or other near-death situation. Durable power of attorney for healthcare names the person who should make healthcare decisions in the event that the patient is incapacitated. So it's a little more flexible in that somebody can, assess what your condition is, but make sure it's someone you really trust to carry out your wishes, because you're handing over those decisions to them in case of you being unable to make those decisions yourself. Medical orders, there's a lot of different types of medical orders, and these are crafted by medical professionals on behalf of a seriously ill patient and must be followed by other medical personnel. Medical orders include physician orders for life-sustaining treatment, a DNR or do not resuscitate, a DNI, a do not intubate, and a do not hospitalize or a DNH. 1/4 of American adults have given little to no thought to end-of-life preferences, and even fewer have written down or even talked to someone about them. This makes it really hard for family members to know what their relative might want in case of these hard situations. We also see some cultural differences in end-of-life decisions, and remember, be careful with generalizations. They don't apply to every single person within a culture. So in many Hispanic, Chinese, Indian, and Pakistani cultures, family members and even doctors typically will try to shield a patient from knowing about the full nature of a terminal illness. Different terms for cancer may be used, such as mass, growth, or even unclean tissue. And that might be used by doctors in Japan as well as several African nations. Doctors, family members, or both may make healthcare decisions rather than only the patient making those decisions. Non-Western cultures do not necessarily use advanced directives, such as in India, where they're very uncommon. Germany, on the other hand, they are a key component of healthcare. So again, definitely differences, culture to culture, country to country, person to person. There are some general group trends, for race and ethnic group trends within the United States when it comes to end-of-life wishes. Generally speaking, white Americans are more likely than Black or Hispanic Americans to report that they would prefer to stop treatment in the case of a terminal illness. Blacks and Hispanics are more likely to say that they would want everything possible to be done to save their lives. So this, as mentioned before, this might be due to religious preferences in terms of, putting it up to God or a higher power to decide if you die or not, and doing whatever you can possible to, come out on the living side. This can also be due to the long history and continued sadly, in many hospitals where people of color are not taken seriously in terms of their pain levels. I mean, the past is littered with horrific studies, some not too far off from current day, in fact, where people of color have been experimented on without their consent by people in the medical profession. And so maybe it could also be due to things like distrust from that. That might spur people to say, hey, try everything, as opposed to, stopping treatment. So could be a few different factors for why we see differences in those numbers. Euthanasia. Euthanasia is kind of an umbrella term that refers to intentionally ending one's life when suffering from a terminal illness or severe disability. And there are many different forms of euthanasia. So active euthanasia refers to intentionally causing death, usually through a lethal dose of medication that is given by a medical professional to the patient directly. So the medical professional is ending the person's life. We also have passive euthanasia, and that is where when life-sustaining support is withheld or withdrawn, and that's actually a common part of medical practice. And then we have physician-assisted dying, or sometimes also referred to as medical aid in dying, or MAID for short. And what this is it's a form of active euthanasia whereby the physician prescribes the means by which a person can die. So they prescribe a lethal dose of medication that the patient then takes on their own. The patient takes it. It is not directly administered by a medical professional. So that's what's the differences between active euthanasia and physician-assisted dying or medical aid in dying. It's legal in 10 states as well as Washington, D.C. In order to receive medical aid in dying, a person must be 18 or older. They must have 6 months or less to live, as determined by at least 2 physicians. So you must be terminally ill. You have to obtain 2 oral requests, at least 15 days apart, and 1 written request. In terms of other countries, Canada and several European countries also allow physician-assisted dying or medical aid in dying. Belgium is the only country as of 2014 to give the right to die to people under 18 years of age. These individuals do need to get parental consent, and they must be suffering from a serious and incurable disease. They must be able to demonstrate that they understand what euthanasia means, and their death must be expected in the near future. So physician-assisted dying or medical aid in dying is controversial. The major areas of disagreement include, first off, whether a person has the legal right to die. Second, whether active euthanasia might become a slippery slope and start a trend towards legalizing death for individuals who might be disabled or unable to give consent. A third concern, how to interpret the Hippocratic Oath of do no harm. So the Hippocratic Oath is taken by medical professionals, and some interpret the Hippocratic Oath of do no harm as, you know, not providing the means to end their life. Others interpret it as, you know, if you're living with a terminal illness and a lot of pain, then doing no harm would be, you know, preventing them from having to experience that pain in those late stages of disease. So, you know, it's not quite as clear cut as it might sound. Also, a concern that's brought up is whether the government should be involved in end of life decisions. You know, like, should we have laws about this? Is that something we want the government having control over, enforcing? And then also specific religious restrictions against deliberately ending a life. So several religions are against ending a life, even if you have a terminal illness, but not everyone's religious. So, you know, lots of different concerns regarding euthanasia. In 2013, about 47% of Americans said that they approved, and 49% said they disapproved of medical aid in dying. And that's been pretty consistent over the years. It changes a few percent. Sometimes it's slightly more people who are in favor of it and slightly more who are against it, depending on the year, but it's very close to a 50-50 split. So getting into some religious practices after death, funeral rites help to provide a sense of closure and to reflect personal and cultural beliefs regarding the meaning of death and the afterlife. In Hinduism, reincarnation is thought to be, what follows your current life. The idea is, you're reborn, you have a new life. The bodies are supposed to be cremated as soon as possible after death, after it's washed, anointed, dressed, and placed on a stand with flowers. After the cremation, the ashes should be dispersed in one of India's holy rivers if possible, such as the Ganges River. For Judaism, they also encourage a quick burial, so should be done as soon as possible. Orthodox Jews will wash the body, wrap it in a simple white shroud with a prayer shawl if the person is male. The body is then put in a plain wooden coffin. A service with prayers and a eulogy is given, and after the burial, the family members sit Shiva, which refers to receiving visitors at their home following the death of a loved one. And I realize this is just, very general. There are, of course, several different sects of Hinduism, Judaism, Islam, Christianity, so on and so forth. I mean, we're just getting a little overview of some of the differences. There's, of course, many other possible funeral rites. So Islam, Muslims also bury their dead as soon as possible, and the community is involved in the ritual. The body is washed and wrapped in a white shroud called a kafan. Kafan? I am not sure exactly how to pronounce that. Funeral prayers are then said, and the body is placed directly into the earth, laying on the right side and facing towards Mecca in Saudi Arabia, a holy site of the Islamic faith. For Roman Catholics, a priest anoints the individual before death, called anointing the sick. He will say prayers and apply consecrated oil to the ill person's forehead and hands, and the person then takes their final communion, their consecrated bread and wine. There are three parts to the funeral rites. First, the wake, which is usually at a funeral parlor where friends and family see the body, pray, give a eulogy. The second part, the funeral mass, a church service, which includes a prayer, Bible readings, a liturgy, communion, and a concluding rite. And then lastly, the funeral moves to the cemetery where the grave is blessed, scriptures are read, and a closing prayer is said. Again, there are many different religious practices and spiritual practices. These are just a few of some of the more common religions. A green or natural burial attempts to reduce the impact on the environment at every stage of the funeral. And this is kind of a newer idea in Western cultures, although other cultures have definitely practiced green burials. For example, many native tribes practice sky burial, leaving the bodies out for scavengers, for animals, vultures to consume. I mean, that's been, going on for far longer. But we've seen a big resurgence in this idea of green burials. And this can involve using recycled paper, biodegradable caskets, cotton shrouds, skipping the embalming process to not put all of those chemicals into the ground, and really trying to maintain the natural environment around the burial site. kind of like in the picture on the slide there. So green or natural burials tend to be cheaper. So typically there's no coffin, no embalming, no concrete vault, all of which, tend to be more expensive and put a lot more heavy metals and chemicals into the ground that are not typically there. There are also various additional options for like using cremated ashes to make artificial reef balls to help restore coral reefs. And over 70 nations have contributed over 700,000 reef balls altogether. Another option, using ashes to help plants grow, although you typically have to add special supplemental enzymes to counter the high pH and sodium levels of human ashes. Human composting is another great alternative. It was first legalized in Washington in 2019. Colorado, Oregon, and Vermont have also legalized human composting as well. So again, ways to help offset the damage to the planet after we die. So grief, bereavement, and mourning. So sometimes people get confused about what the difference is between these concepts. So grief refers to the intense physical, and psychological distress that we have when someone we love dies. So grief, I always think of feelings, grief feelings. It's the F at the end, grief feelings. I know that's weird, but that's how I remember it. So at first, symptoms tend to be pretty intense. They often ease up a bit within 6 to 10 weeks. Of course, it very much depends person to person. Such as with complicated grief, that's where we get what's referred to as an atypical grief reaction, where those feelings of disbelief, preoccupation with the dead loved one, distressing memories, feeling unable to move on with your life, and feeling a yearning for the deceased occurs. The symptoms may last 6 months or longer and mirror major depressive disorder. It does require clinical judgment to be able to distinguish between major depressive disorder and complicated grief. Complicated grief is more likely if a traumatic type of bereavement, like having an unexpected death or multiple deaths or very violent deaths, like due to homicide or suicide. Disenfranchised grief, grief that is not socially recognized, such as death due to AIDS or suicide or perinatal deaths or abortions, the death of a pet, a lover, or an ex-spouse, and psychological losses like a partner developing Alzheimer's. These are losses that do not have formal mourning practices or recognition by others that would help to comfort the grieving individual. And thus they tend to have, well, not tend to, but they may have more intense symptoms of grief due to that lack of social support. Anticipatory grief is grief that occurs when a death is expected and survivors have time to prepare to some extent before the loss. The expectation makes it somewhat easier to bear, not that it's not still sad and horrible, but you're not shocked by it, right? You have some time to prepare yourself. It's the difference there. So bereavement. Bereavement is the experience of losing a loved one by death and the period of time after that loss during which grief and mourning occur. So grief, those feelings, and mourning, that process of adapting to the loss, the culturally specified expressions of your thoughts and feelings as you process the death of a loved one. So some cultures encourage mourning to be done more privately, quietly. Others encourage more outward displays of grief, and holding larger ceremonies for like funerals. So definitely a huge variety of different practices in mourning. Elizabeth Kubler-Ross. First off, there are several models of grief, and none is fully explanatory, but we're going to talk about a couple, Elizabeth Kubler-Ross's and also the dual process model. Elizabeth Kubler-Ross credited with awakening society's sensitivity to the psychological needs of dying patients in America, working off of the ideas started by Cicely Saunders over in the UK. Her theory has been heavily criticized, however, and we'll get to that on the next slide. So Kubler-Ross devised a theory of 5 typical responses initially proposed as stages to how we respond to learning that we're going to die. So you're informed that you have a terminal illness and your death is coming up. So the first is denial. So on learning of your terminal illness, a person may deny its seriousness to try to escape the prospect of dying and the ordeal of dying. They might say, that can't be my test results, you've made a mistake, or it's not really that bad, things like that. Anger, the realization that time is short, may promote anger at having to die without having to have a chance to do everything you've wanted to do. Bargaining, realizing that death is inevitable. A terminally ill person may try to strike a deal with family members, doctors, or God or a higher power for extra time. Like I promise I'll, eat better, I'll give up smoking, I'll do all that good stuff, give me 2 more months, right? Trying to make a deal. Depression, if there's no way they can find to kind of postpone the illness, they may become depressed about their impending loss of life. Acceptance. So Kubler-Ross said that most people who reach acceptance, a state of peace about their upcoming death, do so only in the last weeks or days before death. So some of the criticisms of Kubler-Ross's, Kubler-Ross's theory. Validity is a big concern. Basically, how she gathered data to come up with her theory, she and 4 other graduate students collected data by listening to the experiences of dying people. She then developed her model based on the interviewers' collective feelings about what the people dying were experiencing and what they needed. So there's, concern about a lot of subjective, personal thoughts and feelings influencing their interpretations of what they got from the people they interviewed. And there's also concern that her own grief experiences influenced the development of her stages. So they're concerned with that as well. Other researchers have also challenged the idea that denial and acceptance are beneficial to grieving. Denial is thought to be a barrier between the patient and the medical professionals trying to educate and treat the patient. Acceptance may lead some people to give up on treatments prematurely. And some research has suggested that being optimistic can benefit one's adjustment and even potentially extend your longevity. Another concern, the model has been overgeneralized to apply to anyone who is grieving. And this isn't necessarily Kubler-Ross's fault, but some people have overgeneralized it to say it applies to everyone who's grieving, even though Kubler-Ross's research only focused on people who were terminally ill themselves. The model also implies that grief follows a fixed sequence. And so sadly, some people have, with the best of intentions, tried to force people through the stages to help them through their grief, which, definitely is not a helpful thing to do. Finally, A more current study, the Yale Bereavement Study, conducted between January 2000 through 2003, compared to Kubler-Ross's work, which was done in the 60s, did not find support for her model. It actually found acceptance to be the most common reaction from the beginning. So when people were first told they were terminal. The most common negative feature for the first 2 years was yearning. Other reactions like disbelief, depression, and anger were commonly absent or only minimal. However, it is very helpful that Kubler-Ross's work helped to raise our awareness of the needs of people who are dying, to get better support for people who are terminally ill available to them, and raise that awareness in terms of the medical community as well as individuals, so we can advocate for ourselves also, or for our family members. Another model of grieving is the dual process model. It notes that bereaved individuals must move back and forth between grieving and preparing for their life without their loved one. So they move between this loss orientation and this restoration orientation. And so loss orientation is where they're focused on those feelings of loss and yearning for the deceased. The restoration orientation centers on the grieving individual trying to reestablish their roles and their activities that they had prior to the death of their loved one. And I'll share a personal example of where for me, I feel like this was a very accurate description. This is just anecdotal. I'm not saying everyone necessarily feels this way. But my family, we had one of my grandfathers die a few days before one of my sister's weddings. And, I don't know if you know this, but you really can't cancel a wedding like 2-3 days out. I mean, you could, but it's really difficult. And so, yeah, we really had to kind of go back and forth between this grieving as well as, planning for something really exciting and wonderful. And so it was very kind of a weird, it was kind of a weird process. We made it through, luckily. But yeah, this model resonates personally for me, with trying to deal with loss, but also, kind of switching over to looking ahead too, and living life currently, back and forth there. Very tricky. So let's talk about some of those more complicated grieving situations. Loss of a child, perhaps the most difficult loss that an adult can face. The unnaturalness of a child's death, at least in developed countries, tends to complicate grieving, because a child's not supposed to die before their parents. It just feels wrong. The death of a child increases the risk of physical and mental health problems and even mortality in their parents. Very difficult process. It tends to be sudden, unexpected. Not always, but in many instances for children. Having your parents die when you're an adult, in contrast, much more common, and rarely leads to pathological grief or complicated grief. Adult men who are unmarried and living with their mothers tend to have the most trouble grieving. Generally, a father's death has more negative impacts on their sons than daughters, and conversely, a mother's death has more negative impacts for daughters than sons. This is just a generalization, though. So again, not that it's easy or anything like that by any means, but typically not leading to that more complicated, prolonged grieving. Having your parents die when you're a child, on the other hand, is associated with adjustment problems that can last into adulthood. Loss of an attachment figure can affect a child's basic sense of security. It deprives them of a close emotional tie. And so children are at greater risk of substance abuse, depression, criminal behavior, academic underachievement, and even lower employment as they age. While grief counseling is not usually necessary for dealing with the death of a loved one, Worden has identified 10 red flags that might signal a child needs professional help. If they have persistent difficulty in talking about the dead person, persistent or destructive aggressive behaviors, persisting anxiety, clinging, or fears, somatic complaints. So if they have a lot of stomach aches, headaches, if they're having sleeping difficulties or eating disturbances, if they have marked social withdrawal, school difficulties, or serious academic regression, persistent self-blame or guilt, and self-destructive behaviors. So might be an indication that they may need some professional grief counseling. When speaking about death to a child, it is important to use the actual words rather than euphemisms like passed away or lost, although this is, of course, a bit culturally dependent. But the concern is that children can get confused by euphemisms, by these, more soft terms. So if you tell a child, if a relative died from cancer, they recommend saying they died from cancer rather than saying they got very sick, right? And that's so that the child doesn't worry that if somebody else gets sick, that they're going to immediately, die, right? Or not tell somebody that, oh, well, they're just having a long sleep, right? Instead of saying they died, right? Because again, that can freak children out because they get confused. They think like, oh, now is sleeping like death? Am I going to die in my sleep? Or are my parents going to die in my sleep? It just can cause a lot of confusion. And I mean, we want to kind of buffer and protect children from hard things like death. But you do want to be careful to not confuse them because that can actually lead to more problems. So things to keep in mind. Prolonged grief disorder. So the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revised, that's their newest edition, added the disorder for people who are struggling to overcome a loved one's death for some time and to the extent that it's impacting their ability to function in their day-to-day life. So the diagnostic criteria for this disorder includes having the death of a person close to you. It's been at least 12 months, 1 year since they died. And the individual is still experiencing an intense yearning or longing for the deceased person and or being preoccupied with thoughts or memories of the deceased person, present most days to a clinically significant degree, occurring nearly every day for at least the last month. You also have to have at least 3 of the following symptoms, again, present most days to a clinically significant degree, and to have occurred nearly every day for at least the last month. And clinically significant degree is just kind of a subjective term, honestly, if it's having a severe impairment, essentially, in your life. There's no clear-cut, more objective defined measure of significant degree for these. So again, at least 3 of these following symptoms, having an identity disruption, so like feeling part of yourself has died, a marked sense of disbelief about the death, avoidance of reminders of the person who has died, intense emotional pain related to the death, difficulty reintegrating into one's relationships and activities after the death of their loved one, emotional numbness as a result of the death, feeling that life is meaningless, or intense loneliness following that death. So risks for prolonged grief disorder include increased dependency on the deceased prior to their death. The death of a child or spouse or partner puts one at greater risk. Violent or unexpected deaths, more likely to lead to prolonged grief disorder. And if there are economic stressors involved. The duration and severity of the person's bereavement also must exceed expected social, cultural, or religious norms. So, I mean, this is one of the more controversial disorders in that some people say we're over pathologizing grief. So they're trying to make it clear, like this is talking about, grief that has extended for a very long period of time and to the extent that it is interfering with your day-to-day functioning. Okay, so not saying that you might not still be grieving a year out, but if you're unable to continue your life, then maybe it's a disorder, right? So again, some controversy there. So Kubler-Ross has characterized our society as being death-denying, grief-dismissing world, being a death-denying, grief-dismissing world, which is why she advocated for recognizing the needs of dying individuals and supporting them. And it's true that our culture does tend to encourage people or expect you to grieve privately, quickly, and to medicate suffering with substances or activities. Employers may give you 3 to 5 days for bereavement for an immediate family member, although grief typically takes much longer to process than a few days, and you're probably not springing back into work at peak efficiency that soon. Worden identified 4 tasks to help facilitate the process of mourning. The tasks can be completed in any order and may take varying amounts of time. The tasks are accepting that the loss has occurred, working through the pain of grief, adjusting to life without the deceased person, and starting a new life while still maintaining the connection with the deceased through your memories. Support groups. These can be helpful for people of all ages because they reduce the feeling of isolation by helping you connect to others with similar experiences. You can share your pain as well as your coping strategies. Support groups are often available through religious organizations, hospitals, hospice, nursing homes, mental health facilities, and schools. To resolve grief, it is important to permit yourself to confront all thoughts and emotions associated with the death. Excuse me. Make a conscious decision to overcome grief and realize it will take time. Ask for what you need, so people who would like to help people know what to do, and try to set small goals at first, such as going out to dinner with a friend or taking a home repair class, things like that. It's also important to remember that grief can last weeks, months, and may occasionally resurface years later. There is no one way to grieve. Thank you.